Okay, let's unpack this. Today we're diving deep into respiratory pharmacology. And, for many of you listening, this is probably the most crucial unit for understanding how we manage, well, everything from a simple cold right up to really serious chronic diseases.
Welcome. Yeah, we're pulling together quite a bit of material here, specifically leaning on that core text, pharmacology, and the nursing process. Our aim today is really to give you a strategic shortcut. What are the key drug classes you need to know? Why do they actually work? And, maybe most importantly, what are those high-stakes nursing safety points you absolutely have to prioritize?
Right, the mission is all about strategy
Hmm.
and structure. Because when you really look at the drugs for the respiratory system, they kind of fall into two main camps, don't they? It depends on where in the body they're working and what the goal is.
That's exactly the way to think about it. It's the key organizing idea. So first we'll tackle the upper respiratory tract, the URT. Here, the focus is almost always palliative, just relieving symptoms for things like colds, allergies.
Symptom relief, okay.
Then we shift gears completely to the lower respiratory tract, or LRT. Now we're talking chronic stuff like asthma, COPD. And here, the treatment strategy is much more aggressive, it's long-term, and it really centers on two main goals: opening the airways, bronchodilation, and calming down inflammation.
And the concept that ties this all together, especially for the lower tract stuff, is what we're calling the triple threat, right? Understanding how inflammation, that muscle tightening or constriction, and excess mucus or secretion all play together.
Precisely. If you understand which of those three things a drug is targeting, you instantly know why we're using it and when it's appropriate. So yeah, we'll be explicitly linking every major drug class back to that framework: inflammation, constriction, secretion.
Okay, good. And we'll also hit the kinetics, how long these drugs actually stick around and work, and weave in those really practical nursing process points. The so what for keeping patients safe, knowing what to assess, and how to teach them properly. Hashtag JAGSIRE. Strategic management of upper respiratory tract URT symptoms. All right, let's kick off with the URT. The common cold. It's everywhere. When someone comes in sniffling, sneezing, all stuffed up, what's actually happening inside their nose and throat?
Well, fundamentally, the common cold is a viral infection. Usually it's a rhinovirus, maybe influenza, causing what we call a URI, an upper respiratory tract infection. So this virus invades, and the body triggers this immediate local inflammatory response right there in the nasal lining.
Okay, inflammation is key.
Absolutely. And that inflammation causes the classic symptoms. The body tries to flush out the virus, so you get loads of mucus, the irritation makes you sneeze, and really importantly, those local immune chemicals cause the tiny blood vessels in your sinuses to dilate, to open up.
Ah, so that's the congestion, the swelling.
Exactly. That vasodilation makes the capillaries leaky, fluid seeps out into the tissues, and you get that deep, swollen, stuffy feeling.
So if it's mostly viruses causing this, what's the general approach to treatment? Are we curing it?
Almost never. For the vast majority of colds, the treatment is purely palliative. We're just managing the symptoms to make you feel better. We're not actually killing the virus, unless we know for sure it's something specific, like influenza, where we might have an antiviral. Usually, we don't.
Which brings us to that term you hear a lot, empiric therapy.
That's it. The approach is almost always empiric. It means the choices we make recommending acetaminophen for fever, maybe a decongestant, they're based on what we typically see, on experience, on the most likely cause of those symptoms. It's not based on, say, a lab culture confirming exactly which virus it is.
Makes sense. Now, before we get into the specific drugs for these symptoms, there's a huge safety point we have to cover, especially regarding kids. This really changed things for over-the-counter meds.
Oh, absolutely critical. This is a major public health issue and a key nursing point. Back in 2008, the FDA issued a really strong caution. Do not give over-the-counter cough and cold products to children under 2 years old, period.
And why was that? What were they seeing?
It was directly because of a growing number of reports showing really serious side effects in little ones. Things like dangerous oversedation, slowed breathing, seizures, racing heart rates, and tragically, even some deaths in infants and toddlers linked to these common OTC products.
Wow. And I think the data also showed they weren't even that effective in that age group anyway.
Exactly. So parents were potentially exposing their youngest children to significant risks for very little, if any, proven benefit. The takeaway is crystal clear. Dosing these symptom relief drugs in babies and toddlers is incredibly tricky, the margin for error is tiny, and parents should absolutely avoid self-medicating them. You need to talk to a doctor or nurse practitioner for any respiratory symptoms in that age group.
Okay, let's move on to antihistamines. We usually think of them for allergies, right? Histamine is that chemical causing all the itching and sneezing. So how do drugs like Benadryl or Claritin actually work? What's histamine normally doing?
Right. Histamine is a really powerful chemical messenger in the body. It does a lot of things. It's involved in nerve signals in the brain. It makes capillaries dilate. That causes the redness and swelling you see in allergies. It makes smooth muscles contract, which is relevant in the stomach and definitely in the lungs. And it stimulates secretions like tears, saliva, and that runny nose mucus.
And it uses specific receptors, H1 and H2.
Mostly, yeah. H1 receptors are the main players in allergic reactions, smooth muscle effects, and making those capillaries leaky. H2 receptors are more involved in stomach acid. So the allergy drugs we're talking about, like diphenhydramine or loratadine, are specifically H1 antagonists.
Antagonists,
Yeah.
meaning they block it.
Exactly. Think of it like they're competing for a parking spot. Histamine wants to park at the H1 receptor site to trigger its effects. The antihistamine drug gets there first and occupies the spot, blocking histamine from binding. By doing that, they prevent the downstream effects. Less vasodilation, less leaky capillaries, so less swelling, and reduced smooth muscle contraction.
And you mentioned timing is important here.
Crucial. Antihistamines work best if you take them early in an allergic reaction, ideally before histamine has fully latched on all those receptors and kicked off the whole cascade. They're better at preventing the effects than reversing them once they're in full swing.
Okay. Now, the big difference everyone experiences is between the older ones that knock you out and the newer ones. That comes down to the blood-brain barrier.
Yeah. Absolutely.
Yeah.
This is the key distinction between the generations. You've got the traditional or first generation antihistamines. Diphenhydramine or Benadryl is the classic example. These guys are very lipophilic, fat-loving, so they easily cross that protective blood-brain barrier. This means they block H1 receptors not just out in the body, but also centrally in the brain.
And that's why they make you so sleepy.
Precisely. That central action is the primary cause of the significant sedation, which is often the biggest complaint. They also tend to have a shorter duration, maybe around 4 hours, and kick in pretty quickly, like 15-30 minutes. Plus, they have noticeable anticholinergic effects. They block another chemical messenger called acetylcholine, which causes dryness, dry mouth, dry eyes, constipation.
So the non-sedating, or second-generation agents, were designed to avoid that brain effect.
Exactly. Drugs like loratadine, Claritin, or fexofenadine, Allegra, were engineered to be less lipophilic. They don't cross the blood-brain barrier nearly as easily. So they work mainly peripherally, out in the body where the allergy symptoms are happening, without causing nearly as much drowsiness or other CNS side effects. They often have fewer anticholinergic effects, too.
And the timing is much better for compliance, too, right? Once a day.
Huge advantage. Loratadine, for instance, lasts a full 24 hours. That makes once daily dosing possible, which is way more convenient than taking something every 4 to 6 hours. It was a big improvement for people managing chronic allergies.
Still, even with the newer ones, we need to warn people about side effects, especially with the older drugs.
Definitely. Those anticholinergic effects, dry mouth, is super common, but you can also see urinary retention, constipation, even blurred vision. But yeah, sedation is still the main issue with the traditional ones. And for nursing, we have to be especially careful with older adults. Their metabolism is different, they're more sensitive, and that combination of sedation and anticholinergic effects really increases their risk for falls, confusion, maybe even that groggy hangover feeling the next day, #Tertiary decongestants, shrinking the swell.
Okay, so antihistamines help with the itching, sneezing, runny nose. But what about that feeling of being completely blocked up, the congestion? That's where decongestants come in.
Decongestants are all about shrinking that swollen nasal tissue to let things drain and help you breathe easier. They work by constricting blood vessels. They're vasoconstrictors. The biggest group, and usually the most effective for this, are the adrenergics. They're also called sympathomimetics because they mimic the sympathetic nervous system.
Like a localized fight-or-flight response in your nose.
Kind of, yeah. They specifically stimulate alpha-adrenergic receptors, which are found on those tiny arterioles, the small blood vessels, in your nasal sinuses. When those receptors are stimulated, the blood vessels constrict, blood flow decreases, and the swollen nasal tissues, the turbinates, shrink down.
Okay, less swelling means less blockage, easier breathing.
Exactly. It helps the sinuses drain too. But here's where the delivery route, whether you take it as a pill or use a spray, becomes incredibly important for safety. This is a really crucial concept.
Tell us about that. Oral versus topical.
Okay, so if you take an oral decongestant, like pseudoephedrine though, that's often behind the counter, now you get a slower onset, it's more prolonged, it affects the whole body systemically, and it's generally less potent right there in the nose. But the key advantage, oral decongestants do not cause rebound congestion.
Rebound congestion.
Yeah.
That's the big risk with the sprays, right? Like oxymetazoline, Afrin. Those feel like they work instantly.
They do. They are very potent, very rapid vasoconstrictors, hitting directly on the nasal tissue. Patients love that immediate relief, but, and this is the huge warning, if you use those topical nasal sprays for more than about 3, maybe 5 days max, you run a very high risk of developing rebound congestion. The clinical term is rhinitis medicamentosa.
What exactly is happening there?
Your nasal tissues basically become dependent on that external drug to stay constricted. When the drug wears off, the body overcompensates with massive vasodilation, a huge rebound swelling, and the congestion snaps back, often worse than it was before you even started the spray.
Yeah, you hear about people who can't sleep without their nasal spray right next to them. It becomes a cycle.
It's a really vicious cycle of overuse and dependency.
Yeah.
And that overuse is dangerous because it increases the chance the drug gets absorbed into your bloodstream systemically.
And if these adrenergic drugs get systemic,
Then they act just like adrenaline would throughout the body. You get significant CNS stimulation, nervousness, insomnia, and cardiovascular effects like palpitations, increased blood pressure. That's why they're a definite no-go, contraindicated, for people with conditions that are worsened by vasoconstriction, like uncontrolled high blood pressure or a specific type of glaucoma called narrow-angle glaucoma. Hashtag D antitussives and expectorants. Cough control.
all right, the last common cold symptom, the cough. And with cough meds, we need to know if the goal is to stop the cough or make it more productive, right?
Exactly. First, you have antitussives. These are cough suppressants. We generally only want to use these for coughs that are non-productive, dry, hacking coughs, or coughs that are actually harmful, like maybe after someone's had hernia surgery or major abdominal surgery, where the physical strain of coughing could pop stitches or cause damage.
Okay. And there are different ways they work. Codeine is an opioid antitussive. How does that one stop a cough?
Codeine and other opioid antitussives work centrally. They act directly on the cough control center, which is located way down in the medulla part of the brainstem, and they basically just suppress that cough reflex signal. As a bonus, they also provide some pain relief, analgesia, and they tend to have a drying effect on the airways, which can be helpful.
But the big downside is the opioid risk.
Absolutely. Risk of dependency, potential for abuse, and the risk of respiratory depression, especially at higher doses or in sensitive individuals. That's why they're typically prescription only.
Okay, now contrast that with the common over-the-counter non-opioid, dextromethorphan, like in Robitussin DM.
Dextromethorphan also works centrally, suppressing the cough center in the medulla, kind of like opioids. But crucially, it doesn't have the significant pain-relieving properties, and it doesn't carry the same high risk of respiratory depression or dependency when used at the recommended doses.
But there's a caution there too, isn't there? About abuse.
Yes, unfortunately. At very high doses, dextromethorphan can cause euphoria and hallucinations. It's become a substance of abuse, sometimes called robotripping or skittling. So while it's effective and generally safe at normal doses, we do need to be aware of that potential for misuse, especially with adolescents.
Interesting. And then there's a third type that works differently, peripherally, benzonatate.
Right, benzonatate, the little capsules often called Tessalon pearls, these work completely differently. They don't act on the brain at all. Instead, they work locally in your airways. They actually numb or anesthetize the stretch receptors that line your respiratory tract, the lungs, and airways.
So they stop the signal from even starting.
Pretty much. If those stretch receptors don't get irritated and send the signal up to the brain's cough center, the cough reflex simply isn't triggered. It's a neat peripheral mechanism.
Okay, so those are for stopping coughs. What about when you want someone to cough effectively? To get rid of thick mucus, that's where expectorants come in, like guaifenesin.
Exactly. Guaifenesin, the active ingredient in Mucinex and many other cough formulas, is an expectorant. The idea behind it is that it helps thin out the mucus. It's thought to increase the flow of fluid within the respiratory tract, which helps to loosen and liquefy thick, sticky secretions, reducing their viscosity.
Making it easier to cough up and out.
That's the goal. Thinner mucus is easier to mobilize and expel when you cough. It's available everywhere over the counter.
Now, here's a clinical question, though. We know that drinking plenty of water is really effective at thinning secretions. So how much should we emphasize guaifenesin itself, especially since some studies question how effective it really is on its own?
That's a really good point, and it touches on prioritizing patient education. While guaifenesin is widely used and generally considered safe, the most important thing for thinning secretions is hydration. Good old water. So when we're teaching patients, the primary message should always be push fluids. Aim for maybe up to 3 liters a day, as long as they don't have heart failure or kidney problems that restrict fluids.
So support the guaifenesin with water.
Absolutely. If a patient wants to use guaifenesin, that's fine, but they need to understand that it works best when they are well hydrated. The drug can't magically create fluid. It helps the fluid that's already there work better to thin the mucus. Without adequate hydration, it's likely not going to be very effective. So hydration first, always.
Okay, let's shift gears now. We're moving down from the nose and throat into the lower respiratory tract, the LRT. This is where we manage chronic obstructive diseases, mainly asthma and COPD. Big difference in approach here.
Totally different ballgame. We're moving from just managing temporary symptoms to aggressively controlling chronic conditions long term. Both asthma and COPD involve blocked or obstructed airflow, but how that happens is a bit different.
How so?
Well, asthma is typically characterized by recurrent episodes. You get bronchospasm, the airways suddenly clamp down, plus inflammation and extra mucus. But importantly, this obstruction in asthma is usually reversible, at least partially, especially with treatment. COPD, which now includes conditions previously called chronic bronchitis and emphysema, involves airflow obstruction that's more constant. It tends to get progressively worse over time, and it's not fully reversible.
And if an asthma attack doesn't get controlled, it can become really dangerous, right?
Yeah.
Status asthmaticus.
Exactly. That's a medical emergency. It's a severe, prolonged asthma attack that isn't responding to the usual rescue treatments. It requires immediate, aggressive medical intervention because it can lead to respiratory failure.
And underneath both conditions, the root problem often involves inflammation, doesn't it? That triple threat again.
Yes. Chronic inflammation is a key driver, especially in asthma. Immune system players like IgE antibodies, histamine, again, and chemicals called leukotrienes all contribute to this ongoing inflammation. So our drugs for the LRT have to tackle that triple threat: the muscle constriction, bronchospasm, the excess secretions, mucus, and that underlying inflammation.
All right, let's start with the first line of defense against constriction, the bronchodilators. And the beta-agonists are the big ones here, usually the first thing someone grabs during an attack. How do they actually open up the airways?
Okay, these are also sympathomimetics, like the decongestants, but we want them to be much more selective for the lungs. They work by stimulating specific receptors called beta-2 receptors, which are found in large numbers on the smooth muscle cells lining the bronchioles, the airways in the lungs.
So stimulating beta-2 causes relaxation.
Yes. When the drug binds to the beta-2 receptor, it activates an enzyme inside the cell called adenylate cyclase. This enzyme then ramps up the production of something called cyclic AMP or KAMP.
KAMP, that's like an internal relax signal for the muscle.
Exactly. Increased KAMP levels basically tell the bronchial smooth muscle cells to relax and dilate. This opens up the airways, reduces resistance, and allows air to flow much more easily. That's the bronchodilation effect.
Now, this is probably the single most important distinction in managing asthma. SABA versus LABA. Short-acting versus long-acting. Getting this wrong can be really dangerous.
Absolutely critical. You cannot confuse these. SABA stands for short-acting beta-agonist. Albuterol is the classic example. They work fast. Onset is often within minutes, maybe up to half an hour, but they don't last long, maybe 3 to 4 hours. These are your rescue drugs. They are used only to treat acute symptoms, like during an asthma attack.
But if someone is using their SABA, their rescue inhaler, all the time, say more than twice a week, that's a bad sign, right?
Huge red flag. It means their underlying asthma is not well controlled, and they likely need their maintenance therapy adjusted or increased. Over-relying on the SABA is also risky because at higher doses or with frequent use, the drug can lose its selectivity for beta-2 receptors and start stimulating beta-1 receptors, which are mainly in the heart.
Ah, so that's where side effects like jitteriness and racing heart come from.
Precisely. Stimulating beta-1 receptors causes those common side effects: tremor, nervousness, palpitations, and tachycardia, and increased heart rate.
Okay, so SABAs are for rescue. Now what about LABAs? Long-acting beta-agonists, like salmeterol.
LABAs are completely different. They are controller or maintenance medications. They're designed to provide bronchodilation over a longer period, usually taken on a fixed schedule, often twice a day. They help prevent symptoms. But, and this is the life-saving point, their onset of action is much slower.
So you absolutely cannot use a LABA during an acute asthma attack.
Never. It is extremely dangerous. If someone grabs their LABA inhaler thinking it's a rescue inhaler during an attack, it won't work quickly enough. They won't get the rapid relief they need, the attack can worsen, and it could even be fatal. LABAs are always used for long-term control, and importantly, usually in combination with an inhaled corticosteroid to address the underlying inflammation. Many inhalers actually combine a LABA and a steroid.
Got it. SABA for rescue, LABA for maintenance, never mix them up. You also mentioned non-selective agonists earlier. Why avoid those for routine asthma care?
Right, drugs like epinephrine or adrenaline, they're non-selective, meaning they stimulate alpha receptors, beta-1 receptors in the heart, and beta-2 receptors in the lungs pretty much equally. While epinephrine is absolutely essential for treating severe allergic reactions like anaphylaxis, using it routinely for asthma carries too many risks because of that widespread stimulation. You get significant increases in heart rate, the force of the heart's contraction, blood pressure. It's just too much systemic effect when all you really want is targeted lung relaxation. For asthma, we want drugs that are as beta-2 selective as possible.
Okay, another class of bronchodilators targets a different system. The anticholinergics, we saw them briefly for URT, but drugs like ipratropium or tiotropium are mainstays in the LRT, especially for COPD. How do they work differently?
These drugs work by blocking the effects of the parasympathetic nervous system, PSNS, on the airways. Normally, the PSNS releases a neurotransmitter called acetylcholine, or HE, onto receptors in the airways. This HE causes the bronchial smooth muscle to constrict slightly and also increases mucus secretion.
So anticholinergics block A.
Exactly. They block the ACC receptors on the bronchial tree. Though preventing HE from binding, they prevent that PSNS-driven bronchoconstriction. So you get an indirect bronchodilation because the constrict signal is blocked. And very importantly, especially for COPD, where mucus is a big problem, they also help to reduce secretions.
Are they used for rescue or maintenance?
Definitely maintenance. Their onset of action is slower than SABAs, and their effects last longer. So they're used regularly to prevent bronchospasm, particularly in COPD patients. They're not the first choice for relieving acute symptoms.
And because they're anticholinergics, even though they're inhaled, we still need to watch for those characteristic side effects.
Yes, although systemic absorption is usually low with inhaled forms, it can happen. The main concerns are related to those anticholinergic effects elsewhere in the body. We need to use them cautiously in patients who have conditions that could be worsened by blocking acetylcholine, primarily acute narrow-angle glaucoma, where they could increase eye pressure, and benign prostatic hyperplasia, BPH, or prostate enlargement, where they could potentially cause urinary retention. And dry mouth is a common complaint.
All right, let's talk about an older, potent, but kind of tricky class, the xanthine derivatives. The main one is theophylline. You mentioned it has a narrow therapeutic range. What's its mechanism?
Theophylline works differently again. It inhibits an enzyme called phosphodiesterase, or PDE. Now, remember how beta-agonists increase CAMP-P to cause relaxation? Well, PDE is the enzyme that normally breaks down CAM-MP, cleaning it up.
So theophylline stops the cleanup crew.
Exactly. By inhibiting PDE, theophylline prevents CAMP-P from being broken down. This leads to higher and more sustained levels of CAMP-P inside the smooth muscle cells, which results in prolonged relaxation and bronchodilation.
But it does more than just relax airways, right? It seems to stimulate everything.
It does have broader effects, yes. It also stimulates the central nervous system, which can cause side effects like nervousness, insomnia, even tremors or seizures at toxic levels. It stimulates the cardiovascular system, increasing heart rate and the force of contraction. We call that positive chronotropy and inotropy. And it has a mild diuretic effect, increasing blood flow to the kidneys.
Okay, so given its slow onset and all these other effects, it's definitely not for acute attacks, prevention only.
Strictly prevention, usually for mild to moderate asthma or COPD, but never for rescue. And the absolute critical thing to know about theophylline is its narrow therapeutic range. This is probably the most tested safety point.
What is that range, and why is it so dangerous?
The target therapeutic level in the blood is very small, typically 5 to 15 micrograms per milliliter, mcgml. Below 5, it's generally not effective. But if the level gets much above 15, and especially above 20, the risk of serious toxicity skyrockets. We're talking severe nausea and vomiting, persistent headaches, dangerous heart rhythm disturbances like ventricular dysrhythmias, and seizures. It requires regular blood level monitoring to keep patients within that safe and effective window.
And what makes keeping it in that window so difficult are all the interactions, right? Drugs, food, even smoking.
Huge issue. The metabolism of theophylline is heavily influenced by liver enzymes, and many things can affect those enzymes. First, other drugs can inhibit its metabolism. Things like allopurinol for gout, cimetidine, an older heartburn drug, and certain antibiotics, especially macrolides like erythromycin or quinolones like ciprofloxacin, these can slow down the breakdown of theophylline, causing its levels to rise dangerously high quickly.
Okay, so inhibitors increase the risk of toxicity. What about things that speed up its breakdown?
Right, enzyme inducers. The classic example is smoking. Nicotine significantly speeds up the liver enzymes that metabolize theophylline. This means a smoker typically needs a much higher dose of theophylline than a non-smoker to achieve the same therapeutic blood level, that 515 range.
So what happens if a patient who's stable on a certain dose of theophylline suddenly quits smoking?
That's a critical scenario. If they quit smoking cold turkey, those liver enzymes slow back down to normal. But they're still taking their higher smoker's dose. Suddenly, the drug isn't being broken down as fast, the blood levels surge dramatically, and they can rapidly become toxic. It's a major risk. We also see increased metabolism, meaning lower drug levels, with things like eating charcoal broiled foods regularly or following high protein, low carbohydrate diets. It just makes managing this drug incredibly complex. Constant monitoring and meticulous patient education about lifestyle factors are essential.
Okay, we've hit the bronchodilators hard. Now let's focus squarely on the other major strategy for chronic LRT diseases, tackling the inflammation itself. These drugs don't primarily open the airways, but they calm down that underlying inflammatory process.
First up are the LTRAs, the leukotriene receptor antagonists. Montelukast, brand name Singulair, is the most common one. These are pretty clever drugs targeting a specific part of the inflammatory cascade in asthma.
Tell us about leukotrienes. What do they do?
Okay, so when someone with asthma is exposed to an allergen or trigger, their immune cells release a bunch of chemicals, including leukotrienes. These leukotrienes are really potent troublemakers. They cause inflammation in the airways, they cause the smooth muscles to constrict, bronchoconstriction, and they increase mucus production. They basically hit all three parts of that triple threat.
So LTRAs stop these troublemakers.
Exactly. Montelukast works by blocking the specific receptors that leukotrienes bind to, primarily the D4 receptors in the lungs. It's like putting a cover over the keyhole so the leukotriene key can't get in and unlock the door to cause inflammation, constriction, and mucus.
That's great because it seems to address multiple problems at once.
It does. That's why they're really useful for the prophylaxis, the prevention and long-term treatment of asthma. They're also approved for treating allergic rhinitis.
Are they for rescue or maintenance?
Strictly maintenance. They need to be taken regularly, every day, usually in the evening. They build up their effect over time. You might not notice a difference for a week or so. This is a critical safety point. LTRAs are not for treating acute asthma attacks. They work too slowly.
And there's a significant safety warning we need to mention for Montelukast, isn't there? Despite it being so common.
Yes, very important. In 2020, the FDA added a black box, warning their strongest warning to Montelukast regarding potential serious neuropsychiatric events. This includes reports of things like agitation, aggression, anxiety, depression, sleep disturbances, disorientation, hallucinations, and even suicidal thoughts and behaviors.
Wow, that's serious.
It is. It means patients and caregivers need to be vigilant. Anyone starting or taking Montelukast should be counseled about these risks and told to report any changes in mood or behavior to their healthcare provider immediately. The benefits still outweigh the risks for many patients, but awareness and monitoring are crucial.
Okay, now for the heavy hitters of anti-inflammation.
Yeah.
Corticosteroids or glucocorticoids. These are probably the most powerful drugs we have for controlling lung inflammation. How do they work?
They have a really broad anti-inflammatory effect. One key mechanism is that they stabilize the membranes of inflammatory cells, particularly mast cells and white blood cells like eosinophils and leukocytes. By stabilizing these cell membranes, they prevent the cells from rupturing and releasing all those pro-inflammatory chemicals, histamine, the leukotrienes, prostaglandins, etc., that drive the allergic and inflammatory response.
So they stop the chemical warfare at the source.
Pretty much. They also have other effects, like reducing capillary permeability, decreasing mucus production over time, and importantly, they seem to enhance the effects of the beta-agonist bronchodilators. They make the airways more responsive to those rescue drugs.
Now, the route we give steroids inhaled versus pills or IV makes a huge difference in terms of side effects, right?
Massive difference. This is key. For long-term maintenance therapy of persistent asthma, inhaled corticosteroids, ICS, like fluticasone, Flovent, or budesonide pulmicort, are the preferred first-line treatment. Why? Because the drug is delivered directly to the lungs where it's needed, minimizing the amount that gets absorbed into the rest of the body. This drastically reduces the risk of systemic side effects.
And the systemic forms. Prednisone pills, IV methylprednisolone.
Those systemic corticosteroids are generally reserved only for treating acute, severe exacerbations of asthma or COPD, like a bad flare-up that requires hospitalization. They provide powerful, widespread anti-inflammation quickly, but they come with a much higher risk of side effects if used long-term.
Okay, for the inhaled steroids, what's the single most important piece of patient teaching? The one thing everyone forgets.
Rinse and spit. Patients must rinse their mouth thoroughly with water and then spit it out after every single dose of their inhaled corticosteroid.
Why is that so critical?
Because the steroid suppresses the immune response locally in the mouth and throat, this creates a perfect environment for opportunistic infections, specifically oral candidiasis, which is a fungal infection commonly known as thrush. Rinsing removes any residual medication from the oral cavity, significantly reducing that risk.
Got it. Rinse and spit after every ICS use. Now let's talk about probably the most dangerous potential issue with steroids. Switching from long-term systemic steroids, PILSBUV, back to inhaled ones. This involves tapering and the risk of adrenal crisis.
This is absolutely life or death patient safety knowledge. If a patient has been taking systemic steroids, say prednisone pills, every day for weeks or months, their own adrenal glands stop producing cortisol, the body's natural stress hormone. The body senses it's getting steroids from the outside, so it shuts down its own production line. This is called adrenal suppression or HPA axis suppression.
So their body isn't making its own essential stress hormone anymore.
Correct. Now, if you suddenly stop the external systemic steroid, if the patient just stops taking their prednisone pills, or a clinician abruptly discontinues it, the body is left with potentially zero cortisol. Cortisol is essential for maintaining blood pressure, blood sugar, and coping with stress.
And without it.
The patient can go into a state of shock, a life-threatening condition called an Addisonian crisis, or acute adrenal insufficiency. Symptoms include severe fatigue, dizziness, low blood pressure, nausea, vomiting, abdominal pain, and potentially collapse and death if not treated immediately with IV steroids.
So how do you safely make that switch from systemic to inhaled?
You must taper the systemic dose slowly, very slowly, sometimes over weeks or even months, depending on how long and at what dose the patient was taking the systemic steroid. This gradual reduction allows the patient's own adrenal glands time to wake back up and gradually start producing cortisol again. You cannot rush this process. It requires careful monitoring and a clear tapering schedule. Never ever abruptly stop long-term systemic steroids.
Okay, that's a critical warning. And even when tapered correctly, long-term systemic use still carries risks, right? Like Cushing symptoms.
Yes, even with appropriate use for necessary conditions, prolonged systemic steroid therapy can lead to a range of side effects that resemble Cushing's disease, which is caused by excess cortisol. Things like fluid retention, moon face, buffalo hump, weight gain, mood swings, increased susceptibility to infections, thinning skin, easy bruising, high blood sugar, bone density loss leading to osteoporosis, and in children it can suppress growth. This is exactly why we strive to use the lowest effective dose for the shortest possible time and transition to inhaled steroids for maintenance whenever feasible. #TAC newer agents.
Before we move to nursing process, let's quickly touch on some of the newer players showing how targeted respiratory therapy is becoming.
Right, we're seeing drugs that hit even more specific pathways. One example is the phosphodiesterase 4, PDE4 inhibitors like roflumilast. Remember, theophylline was a non-selective PDE inhibitor. Well, PDE4 is more specific to inflammatory cells involved in COPD.
So more targeted, maybe fewer side effects than theophylline?
Potentially fewer cardiovascular and CNS side effects, yes. Roflumilast is specifically indicated to reduce the risk of COPD exacerbations in patients with severe COPD associated with chronic bronchitis and a history of flare-ups. It mainly helps with coughing and excess mucus, but again, it's not a bronchodilator and not for acute relief. It also has its own set of potential adverse effects, notably psychiatric ones like insomnia, anxiety, depression, and weight loss, so it comes with a medication guide.
And then there are the really high-tech ones, monoclonal antibodies. These sound complex.
They are. These are biologic drugs, large protein molecules created in a lab, usually given by injection or infusion. They are typically reserved as add-on therapy for patients with severe persistent asthma that's not well controlled by standard treatments like high-dose inhaled steroids and LUTAs.
How do they work?
They target very specific molecules in the inflammatory pathway. For example, omalizumab, Xolair, targets and binds to immunoglobulin E, IgE, the antibody that drives allergic asthma. By neutralizing IgE, it prevents it from triggering the allergic cascade. Other monoclonal antibodies target specific interleukins, which are other signaling molecules involved in inflammation, like mepolizumab or benralizumab targeting IL-5, which is important for eosinophils.
What are the main risks with these biologics?
Because they are foreign proteins, the primary risk is hypersensitivity reactions, including, rarely, severe anaphylaxis. This risk means they often need to be administered in a healthcare setting where allergic reactions can be managed immediately, especially for the first few doses. Patients also need careful monitoring.
Okay, we've covered a huge amount of pharmacology. Let's bring it all back to the bedside. Applying the nursing process. Before giving any of these respiratory meds, what's the absolute priority assessment?
Baseline, baseline, baseline. And looking for signs of trouble. You need a full set of respiratory vitals, rate, rhythm, depth of breathing, and definitely pulse oximetry, oxygen saturation. But don't just rely on the numbers. Look at the patient. Are they using accessory muscles to breathe? Is there any cyanosis, bluish tint around the lips or nail beds? Are they retracting, pulling in muscles between the ribs or at the sternum?
And you mentioned behavior earlier.
Yes, critically important. Assess their level of consciousness and behavior. Restlessness, agitation, or unexplained anxiety can be the very first subtle sign of hypoxia, lack of oxygen getting to the brain even before the O2 sat drops significantly. Don't dismiss restlessness in a respiratory patient.
Good point. What else in the history is vital?
You need to know their triggers. What sets off their asthma or COPD? Allergens, smoke, cold air, stress, exercise. Also confounding factors. Do they drink a lot of caffeine? Caffeine is of xanthine, like theophylline, and can increase heart rate and jitteriness, potentially worsening side effects of beta-agonists. Definitely need their smoking history, especially if theophylline is involved.
And for the theophylline, specifically check.
Any history of heart problems, especially arrhythmias. And absolutely confirm when their last blood level was drawn and if it was within that tight 515 ml/gml therapeutic range before giving the next dose. #B, implementation and patient teaching. The how-to.
All right, assessment done. Now for implementation. We already talked about hydration being key.
Absolutely. Encourage fluids up to 3 liters a day if their heart and kidneys can handle it to help liquefy those secretions. It's the best non-drug expectorant. But probably the most crucial implementation piece, especially for outpatients, is teaching correct inhaler technique.
MDI, DPI.
Yeah.
If they don't use it right, the drug doesn't get where it needs to go.
Exactly. Efficacy plummets if technique is poor. Using a spacer device with MDIs is often very helpful, especially for kids and older adults. And patients need return demonstrations to show they can do it correctly.
What about when a patient needs to take 2 different inhalers? Say, a rescue inhaler and a steroid inhaler. Is there a specific order?
Yes, absolutely fundamental. Always use the bronchodilator first. That's usually the beta-agonist, the SABA or LABA. Use that inhaler, wait about 2 to 5 minutes, give it time to open up the airways fully, and then use the second inhaler, which is typically the anti-inflammatory corticosteroid.
Why that order?
Because opening the airways first allows the second medication, the steroid, to penetrate deeper into the lungs and reach more surface area, making it more effective. If you use the steroid first on constricted airways, less of it gets down where it needs to work. And also remember, if taking multiple puffs of the same drug, wait 1 to 2 minutes between puffs.
Good tips.
Yeah.
And a quick reminder about those oral sustained release pills, like theophylline.
Yes. Crucial safety point. Never crush or chew any sustained release or extended release tablet or capsule. Doing so destroys the time release mechanism, causing the entire dose to be absorbed at once, called dose dumping. This can lead to sudden, dangerously high blood levels and severe toxicity. They must be swallowed whole.
Okay. And finally, the adherence challenge with chronic meds. People feel better, they stop taking their controller inhaler.
This is maybe the biggest challenge in long-term management. We have to constantly reinforce that maintenance medications, the LABAs, the LTRAs, and especially the inhaled steroids, must be taken every single day as prescribed, even when the patient feels perfectly fine. These drugs are working silently in the background to control the underlying inflammation and prevent future attacks. Stopping them allows the inflammation to creep back, setting them up for the next exacerbation.
And a quick safety recap for the URT drugs.
Yeah, just remind patients about that risk of rebound congestion with the topical nasal decongestant sprays no more than 3 to 5 days, and tell them to report worsening symptoms. A fever over 100.4 degrees F38 degrees, or symptoms like congestion or cough that drag on for more than, say, 3 or 4 days without improving, as it could indicate a secondary bacterial infection. #C evaluation, what success looks like.
So after we've assessed, intervened, educated, how do we know if the treatment is actually working? How do we evaluate success?
We look for objective improvements, not just subjective feelings. Is their wheezing decreased or absent on auscultation? Has their respiratory rate come down to a normal range? Is their oxygen saturation improving or staying stable at a good level, usually above 92–94%, depending on baseline? And a really important functional measure. Has their activity tolerance improved? Can they walk further, do more daily activities without getting short of breath? Can they sleep through the night without waking up coughing or wheezing?
And you mentioned a tool patients can use themselves at home, the peak flow meter.
Yes, the peak flow meter is a fantastic tool for patients with asthma, especially to monitor their own lung function objectively. It measures their peak expiratory flow rate, how fast they can blow air out in one quick burst.
How does that help?
We help them establish their personal best reading when their asthma is well controlled. Then they use the meter daily, usually in the morning, and compare the reading to their personal best. It gives them an early warning sign if their airways are starting to narrow, often before they even feel significant symptoms. We teach them the zone system. Green zone, 80–100% of personal best, means good control. Yellow zone, 50–80%, means caution, airways are narrowing, maybe need to use rescue inhaler or adjust meds per their action plan. Red zone, below 50%, is a medical alert, significant obstruction, need rescue inhaler immediately, and likely need to seek medical attention. It empowers patients to manage their condition proactively.
That's great. And finally, evaluation always includes monitoring for side effects specific to the drug classes we talked about.
Absolutely. Always be vigilant. Watch for signs of cardiac stimulation, tachycardia, palpitations, tremor, especially with beta-agonists and theophylline. Ask about anticholinergic effects, dry mouth, constipation, urinary issues, particularly with ipratropium or tiotropium. And definitely keep monitoring for any mood or behavior changes in patients taking LTRAs like montelukast, remembering that black box warning. #OutCheckOutro. So when you step back and look at this whole unit, you really see this incredible progression in how we approach respiratory problems pharmacologically. We start with relatively simple strategies for the URT, blocking histamine for allergies, shrinking swollen vessels with decongestants, basic symptom management.
But then for the chronic LRT diseases, it gets way more sophisticated. We're targeting specific receptors like beta-2, blocking inflammatory chemicals like leukotrienes, using powerful anti-inflammatories like steroids, and even developing biologics like monoclonal antibodies that hit very precise molecular targets.
Exactly. It moves from just symptom relief to really trying to control the underlying disease processes long term. And the common thread, the big takeaway through all of it, has to be understanding the power and the responsibility that comes with using these drugs.
Yeah, you really hammered home those safety points. The incredibly narrow therapeutic window for theophylline, where just quitting smoking can throw someone into toxicity, or the absolute necessity of slowly tapering systemic steroids to prevent a life-threatening adrenal crisis. These aren't minor details, they're critical for patient safety.
They absolutely are. Administration timing, route, patient education on technique and adherence, it all matters immensely.
So to leave our listeners with something to think about, you mentioned drug delivery systems changing, like the move from older CFC inhalers to the newer HFA ones for environmental reasons. That forced patients to learn slightly different techniques.
Right, the force of the spray felt different, the priming instructions changed, and now we see more push towards dry powder inhalers, DPIs, which require a different kind of breath actuation compared to the press and breathe technique of metered dose inhalers. Nice.
So the provocative thought is, as technology and even environmental regulations continue to dictate changes in the devices we use to deliver these respiratory drugs, how might that constant evolution in the delivery mechanism itself, totally separate from the drug molecule, impact things like patient adherence, ease of use, and ultimately how effective the therapy is? It really highlights how pharmacology doesn't exist in a vacuum. It's always interacting with human factors and technology.
That's a great point to ponder. It emphasizes the need for ongoing patient education and assessment of technique, no matter how long someone has been using respiratory meds. Well, thank you for taking this pretty deep dive into respiratory pharmacology with us today.
We really covered a lot of ground. We hope you feel much more confident navigating these crucial medications. Thanks for tuning in, and we'll catch you on the next deep dive.